How do you get that balance right between process, business model, and technology, between South and North? And I think more importantly is what could we learn from the principles adopted in the South when it comes to innovation? And these principles are things that I think we missed out on in the North, things like affordability. I don't think affordability is in the radar screen when there's a new innovation about to be introduced in the North, but I think that is changing with the current times of austerity. It needs to be scalable, and I'm not entirely sure we design or we introduce innovation in the North with the idea of scalability, although that's always been a challenge. Certainly in our own healthcare system in the UK, that has been of the greatest challenge. And also, it needs to be of the highest quality. And now combining these three words together, which I very much hope will be the pillar of the discussion today, affordability, scalability, and quality, is extremely important.
First of all, I would sort of argue or make the case that the notion of reverse innovation is actually a badly named choice. It suggests a reasonably two-dimensional approach to this, and I think we're very much seeing much more multi-dimensional, networked, clustered world of innovation and partnerships. You could argue that studying innovation is a bit of an oxymoron, but there are actually some fairly predictable paths for industry innovation. And then when you look at what social sector innovation looks like, you typically see the toss it over the fence process a little more explicitly. We often see there's not kind of hardly any reference to end users, consumers, market adoption in some of the early R&D work that's funded in the social sector. So I think that's one of the areas. I spent a lot of time in the last couple of years working particularly on Chinese R&D and manufacturing, but as it might apply to opportunities in health and development in sub-Saharan Africa. And what we saw there exactly is what you were saying, is that it's not a matter of just taking a product or an idea and then just shipping it over and transferring it over. The lack of clear distribution models that actually are appropriate for that technology, the whole cost structure of maintenance and support that's required behind the technology transfer is really where the missing link was in our ability to scale that up yet. So I feel like the focus on uptake and scale is essential.
What I wanted to share was some of the lessons learned that we've experienced as we go into emerging markets to develop technologies and drive adoption of those technologies. The first thing I think we learned is that we need partnerships. We're good at what we're good at, developing technology, scaling that technology from a manufacturing perspective, but we don't necessarily know the day in life of a midwife in rural Indonesia or a primary care physician in sub-Saharan Africa. Now our approach when we go into a country, rather than tell what the solution is, we ask a lot more and we look for partners on the ground first and foremost. The second thing is around innovation, and it's been mentioned a couple times today, is that innovation has to go beyond technology. And as we go into emerging markets beyond the top of the pyramid in those emerging markets, is how do we drive innovation adoption, technology adoption, and the innovation really comes out around business model and going beyond just the initial purchase. The last piece and some of the new paradigms that are coming in is we have to drive the adoption of these to reduce maternal infant mortality or whatever goal that the country has, is adding to the technology and the innovation around the business model is education. There's a more and more shortage of resources, either that or the resources are located in the places where they're not needed the most. So educating people that haven't been to medical school for 8 years on how to use these technologies is really important. And our role in industry is to make those technologies easier to use.
A related question, which sort of came up, I think actually came up when Sally yesterday said she had a washing machine with 57 programs and she only uses 3. Now, you talked, Jay, a bit about actually providing the equipment that actually is needed for the conditions of the local environment. Why don't you, having designed it for the local environment, why don't you bring your washing machine that's only got 3 programs back to America and Europe? Why do we still have the washing machine with 57 programs? Does that make sense? Is the analogy a poor one? Why don't you do a simpler model that you may develop in a low and middle income country, and why don't you take that to the high income country?
I think we at the beginning, we did design the simple program at the beginning.
Yeah.
That's because of the company coming from the emerging market really know what's needed.
Yeah.
But when you go to global scale, for us, we go to the developed countries, you need to do something change also. It's same as a multinational go to the emerging markets. The reverse engineering coming from the emerging market, when you go to the developed countries, the habit of using the machine is different as the people using the emerging market. So they need to change something. But depending on what kind of customer you want to target, right? In the developed countries, you still have the low to mid-end segment. You want to target this segment or the high segment. If the higher segment, probably this kind of designing need to be changed a little more. But if the low to mid segment, something, if they are more care about the cost, quality, or some simplicity of the using machine, you got a chance. Otherwise, you need to design in different ways to design product.
You used an interesting word there, which was that actually in high-income countries, people may have the habit, I think you said, of having a different sort of a habit and a different expectation. Do you think that will change as we... But
unfortunately, most of habits were educated by multinational, right? They educate them in the very complex ways.
Yeah.
And then you need to charge more. But they forget what they really needed.
Yeah.
So sometimes don't need too much. Only need a very simple answer for some specific purpose. So that's what we did.
I think we have to provide services at the same level to all in the community, in the meaning whether they can afford, whether they are middle income, whether they are poor. Maybe the offering of the services has to be the same, but the way you offer it, maybe the way the place they stay or the kind of services they get can be different. But the quality of the surgical point should be almost the same. That is one thing, which is a kind of a social marketing which drives you. And that brings in more of patients back into the system. So that is how the Aravind model has been working. And in my case, I'm a cataract and a glaucoma person, but I do almost like 60 to 70 cataracts a week on a high-tech machine. But if you see, the cost is like a fraction of a cost what it can be here or in Africa. So the cost can definitely come down if you optimally use it and where you have a team of people working around you. So that is the key, I think. If most of the work is taken care by, I won't say less skilled, but a kind of a repetitive skilled people. So we have a group of team called the mid-level ophthalmic personnel. So wherever I think if you want to practice this model, this kind of a training program is very important, wherein they do most of the repetitive jobs so that the clinician really focuses on what he really wants to do is best, like doing a surgery or examining a patient. The scalability of the program, I think if you take the Aravind model, we have not gone beyond the state of Tamil Nadu for various reasons, but we have tried to do consultancy and capacity building to develop so many Lions Eye hospitals and Rotary Eye hospitals in the country. And there are a lot of success stories and failures, but we have seen a lot of success stories. And we believe that it will be good for the local players to do because they understand the community better and they know the people better. The culture also orients to them. So we try to do a kind of a capacity building and develop them so that they can provide effective eye care service in this part.